Hello everyone, welcome to this new video to continue our talk about autonomic nervous system pharmacology. In this lecture, we will talk about adrenergic agonists or sympathomimetic drugs or adrenomimetics. These class of medications are important in many clinical conditions in our lives. As a reminder for my lecture roadmap, we are at this stage of autonomic nervous system pharmacology. As a reminder as well, autonomic nervous system is classified into parasympathetic nervous system and sympathetic nervous system, which are parts of efferent nervous system that coming from the peripheral nervous system. Also, as a reminder, these are the differences between sympathetic and parasympathetic nervous system. It is very important to understand the effect of both of these systems on different tissues, as we can see on the left side, and we can see the differences between the sympathetic and parasympathetic nervous system effects on these tissues. In conclusion, the sympathetic nervous system will produce a fight or flight response that happens to the person when this sympathetic nervous system is activated. Today's lecture is about drugs that will mimic the fight and flight response. To start with, we need to remember the life cycle of catecholamines. Catecholamines are a group of drugs that share a common chemical structure, which is the catechol. The synthesis of these catecholamines start with the amino acid tyrosine, where it's through two steps of using enzymes into the presynaptic neuron, they will produce dopamine. After dopamine, after the synthesis of dopamine, it will be transported into the vesicles through a vesicle transporter, and inside the vesicles, there are some enzymes that can transform dopamine into norepinephrine and epinephrine. Upon activation of the presynaptic neuron, there will be a fusion of the vesicles containing the neurotransmitter, either dopamine or norepinephrine or epinephrine, toward the synapse. After that, going into the synapse, it will bind to the postsynaptic receptors. We have different subtypes. We have alpha 1 and alpha 2. We have beta 1, beta 2, and beta 3. And we have dopamine receptors. The effect of these neurotransmitters can be terminated by two enzymes, catechol O methyltransferase or monoamine oxidase enzyme. Also, another way of ending the action of this neurotransmitter is by the reuptake of these neurotransmitters back into the presynaptic neuron, where it can be used for future use when the presynaptic neuron gets activated again, as we can see here. So again, we have multiple receptors and multiple subtypes of these receptors. We have alpha, beta, and dopamine. Each one of them are located in specific tissues, and depending on that tissue, they will produce different effects. Let's go into each one of them one by one. To start with, we will go over alpha 1 receptors. They are located in blood vessels, and in these blood vessels, especially the ones that are go to the skin and to the GI tract, they will produce, the activation of alpha 1 receptors will produce vasoconstriction. In the eye, it will produce mydriasis or widening of the pupils, and in the bladder, it will relax the smooth muscle of the bladder, but at the same time, it will constrict the sphincter from the urinary bladder to the urethral opening. This is very important when we talk about the pharmacology of alpha 1 agonists and antagonists. Thus, we expect that giving alpha 1 drug will produce vasoconstriction of peripheral vascular system that may lead to hypertension or increased blood pressure, mydriasis, and urinary retention. Alpha 2, they are mainly located into the presynaptic neurons, and the activation of these receptors will lead to negative feedback inhibition of further release of a neurotransmitter, as we see in this figure. Thus, these drugs are usually producing inhibitory effects, and that's why, as we will see later, drugs that activate alpha 2 receptors will be indicated to decrease norepinephrine release, and that may help in treating some conditions such as hypertension. Also, alpha 2 receptors are located into the pancreas, and the activation of these receptors will decrease insulin secretion, and that will lead to an increase of glucose levels in the blood. Moving to beta 1 receptors, beta 1 are mainly located into the heart. Activation of these receptors will produce positive inotropic effect, positive chronotropic effect, and positive dromotropic effect, which means increase in contractility, increase in heart rate or tachycardia, as well as increase in electrical conductivity in the heart. Also, beta 1 receptors are located in the kidney, and the activation of these receptors will lead to the secretion of renin. Renin is an important enzyme for the RAS system that will eventually lead to an increase in blood pressure. Moving to beta 2 receptors, they are located in the bronchial tree, and the activation of these receptors will lead to increase in bronchial diameter, so bronchodilation, as well as these receptors are also located in the liver, and they will enhance the glycogenolysis, and this will lead to increased glucose levels in the blood. Finally, beta 2 receptors are also located into the blood vessels, but this time the blood vessels that are going to the skeletal muscles, they will be vasodilated upon the activation of beta 2 receptors. The activation of beta 2 receptors that will lead to vasodilation into the skeletal muscles will lead to increased blood flow toward the skeletal muscles, and that will decrease blood pressure in these specific arteries, as well as they may also enhance the presence of a tremor because of this vasodilation. For beta 3 receptors, they are located in the smooth muscles of the bladder. They are not located in the sphincter, only in the bladder, and the activation of these receptors will lead to the relaxation of these smooth muscle and urinary retention. Also, they are also available into the adipose tissue, and the activation of these receptors will lead to lipolysis and increase of fatty acids in the blood. Finally, dopamine receptors are mainly located into the brain. However, D1 receptors are also located into the kidney, and the activation of these receptors will produce vasodilation into the artery that is going to the kidney and increase blood flow toward the kidney. This slide summarizes all the effects that are associated with each receptor subtypes. And please pay attention to the color code of each effect and to the receptor subtype that's related to these effects. Also, please remember that there are also other effects that are not mentioned here. For example, beta 2 receptors activation can also lead to uterine relaxation, and that sometimes would be helpful clinically. Another important thing I want you to worry about is that some of these effects that may be contradicting other effects through another receptor subtypes. For example, alpha 1 activation will lead to vasoconstriction, while beta 2 activation will lead to vasodilation. Based on this information, Adrenomimetic agonists can be classified into multiple classifications. They can be classified into direct acting and indirect acting. Indirect acting can be classified into either a releaser, which means increase the release of norepinephrine or a neurotransmitter in general, as well as a reuptake inhibitors, which inhibit the process of reuptaking the neurotransmitter into the presynaptic neuron. Direct acting adrenomimetic agonists can be classified into alpha agonists and beta agonists. Alpha agonists in turn can be selective to alpha 1 or selective to alpha 2 or be non-selective to either of subtypes. Beta agonists can also be classified into beta 1 selective, beta 2 selective, and non-selective type. The next few slides will discuss examples of each one of these drugs and classification and the advantage and disadvantages of each one of them. These are examples of direct and indirect acting adrenergic agonists. For direct, we have epinephrine, norepinephrine, albuterol, dobutamine, dopamine, and isoproterenol. For the indirect, we have amphetamine. We have other examples that we will come to them later. Now there is one exception to this rule. We have a couple of drugs that are called mixed adrenergic agonists, where they actually have both indirect and direct effects on the receptor as well as the release of the neurotransmitter. Let's start with the first type, which are the indirect agonists. We have both releasers that increase the release of the neurotransmitter from the presynaptic neuron toward the effector tissue. As well as we have reuptake inhibitors. Indirect adrenergic agonist with increasing norepinephrine release is amphetamine. Amphetamine will be further discussed in the central nervous system topic about the drugs of abuse, so its main function is inside the central nervous system. And as we can see in this figure, in the case of there is no dopamine, this is regular physiology where neurotransmitter will be released upon the activation of the presynaptic neuron to release norepinephrine, serotonin, and dopamine. In the presence of amphetamine, this will increase the process of this release, and that's why they are called releasers. They will definitely increase the blood pressure because they will increase norepinephrine release toward the effector tissue. As an example of the norepinephrine reuptake inhibitor, we have cocaine as an example, where it will block the process of reuptaking the norepinephrine neurotransmitter into the presynaptic neuron, and that means that the norepinephrine will stay for a longer period in the synapse and producing more effect. Let's move to the direct acting adrenomimetic agonists. This graph is very important, that showing different drugs with their different selectivity to the receptors and receptor subtypes. For example, if you look at epinephrine, it has equal selectivity toward alpha, which is in the top pane right here, and beta receptor subtypes. Compare that to norepinephrine, which has selectivity for beta 1 over beta 2, but it has no selectivity between alpha 1 and alpha 2. We have other examples in this graph, such as Clonidine, which is very selective for alpha 2 receptors. We will go into each one of them, and let's start with epinephrine. Epinephrine is the prototype of sympathetic agonist drugs. It is a catecholamine, and it is synthesized in our adrenal medulla. It is released after the activation of the preganglionic neuron that reaching the adrenal medulla, or it can be given externally by giving epinephrine directly. As mentioned in the previous slide, it affects both alpha and beta receptors without selectivity to a specific subtype. Thus, you would expect that it will produce the effect on alpha 1, alpha 2, beta 1, and beta 2 receptors, as we can see here. So it will produce vasoconstriction, mydriasis, urinary retention, decrease insulin, inhibition centrally of alpha 2 receptors, increase heart rate and contractility, increase renal secretion, bronchodilation, glycogenolysis, as well as vasodilation for the arteries going to the skeletal muscles. It will produce all of these effects. For this multiple targets, epinephrine is an essential drug, and sometimes it can save lives and a drug of choice for some conditions, especially anaphylaxis. In anaphylaxis, there is a decrease in blood pressure, and the patient's life depends on increasing the blood pressure and maintaining the airways. So epinephrine will reverse the bronchospasm and the laryngeal edema produced during anaphylactic shock. Epinephrine is given, as you can see in the figure, intramuscularly in the thigh, and this process can be repeated after 10 or 15 minutes if the case is not improving after the first injection. Also, because of its bronchodilator effect, it can be helpful for patients who suffer from asthma, especially during acute attacks. It can be also helpful in cases of cardiac arrest because it stimulates the heart and also produces vasoconstriction. It can also be added as a local anesthetic, and that will decrease the blood flow to the area where the doctor is working, and that will definitely decrease the bleeding, as well as it will decrease the absorption of the active ingredient of local anesthetic to the systemic circulation, so it will increase the duration of action of the local anesthetic. It can be given IV, IM, subcutaneous, and inhalational. Moving from epinephrine to norepinephrine, and as you can see here, it has equal affinity and selectivity between alpha 1 and alpha 2, but for beta subtype, it is a specific targeting beta 1 receptors without affecting beta 2 receptors. So it is alpha 1, alpha 2, and beta 1 agonist. Thus, it has no bronchodilator effect, as well as it does not target the blood vessels that go into the skeletal muscles. So it will not produce vasodilation on these blood vessels. It can be administered IV infusion. Look at the effects of norepinephrine. Unlike epinephrine, it has no effect on glycogenolysis or a bronchospasm and will not produce bronchodilation. Also, it will not produce a vasodilation in the blood vessels that are going to skeletal muscles. This will leave alpha 1 receptors alone without opposing effect from beta 2, and that will produce a huge increase in what's called total peripheral resistance that will lead a huge increase in blood pressure. As a reflex in our body, a huge increase in blood pressure will be coped by a decrease in the heart rate. So thus norepinephrine will not produce tachycardia as expected, although it targets beta 1 receptors that are located in the heart, but because the reflex of the severe increase in blood pressure will produce a reflex bradycardia. Let's see the difference between norepinephrine and epinephrine on cardiovascular system. As I mentioned earlier, norepinephrine targets the alpha 1 receptors and does not target beta 2 receptors that are responsible to produce vasodilation. So the major effect on blood pressure is an increase in blood pressure. On the other hand, epinephrine has alpha 1 effect that produce increase in total peripheral resistance, but at the same time it also targets the beta 2 receptors that produce vasodilation and will decrease the total peripheral resistance. The mean of this effect on blood pressure is actually very little increase or decrease in blood pressure. Looking at the heart rate, As a reflex for this massive increase in blood pressure, there is a decrease in the heart rate, or what we call reflex bradycardia. Here, we don't have an increase or decrease in blood pressure, so the only effect will happen that the effect of epinephrine on beta 1 receptors that are located in the heart will produce increase in heart rate and tachycardia. Let's move to another drug which is equal selectivity for beta 1 and beta 2, and that is isoproterenol. So isoproterenol will only affect beta 1 and beta 2, and that will leave the increase in heart rate, bronchodilation, increased glycogenolysis, as well as vasodilation of blood vessels that going to skeletal muscles. Looking at the same graph to compare it with epinephrine and norepinephrine, isoproterenol, it will produce decrease in the blood pressure because it will target beta 2 that produce vasodilation, and that will produce a reflex tachycardia, as well as the direct effect of isoproterenol on beta 1 that will produce massive increase of the heart rate even further compared to epinephrine and norepinephrine because of these two factors, the direct effect of beta 1 as well as reflex tachycardia due to the decrease of the blood pressure. Again, isoproterenol does not target alpha 1, and that's why it does not produce increase in blood pressure. It's a synthetic catecholamine, targets only beta receptors, it stimulates the heart, dilates the blood vessels toward the skeletal muscles, and produces bronchodilation. For that reason, it can be used for patients who suffer from asthma because of its bronchodilator effect, as well as for patients who suffer from some sort of heart block. This graph is the same as the previous graph, where it compares between norepinephrine, epinephrine, and isoproterenol in the cardiovascular system. Norepinephrine will increase the total peripheral resistance because it only affects the alpha 1 receptors without opposing effect of beta 2 receptors. That will lead to an increase in the blood pressure and a decrease in the heart rate as a reflex bradycardia. Epinephrine does not change the total peripheral resistance that much, and the blood pressure will be changed a little bit, and the heart rate will increase because there is no reflex to compensate, and the only effect is the direct effect of epinephrine on beta 1 receptors. For isoproterenol, there is a massive decrease in total peripheral resistance due to the direct effect on beta 2 receptors, and that will lead to a decrease in blood pressure, and that will lead to a reflex tachycardia, as well as direct effect of isoproterenol on beta 1 receptors on the heart. Let's move to a more selective drugs, and let's start with alpha 1 selective agents. An example of this drug is phenylephrine. Phenylephrine will produce vasoconstriction due to direct effect on alpha 1 receptors on the blood vessels. It will produce mydriasis and will produce urinary retention. For that reason, phenylephrine is an example of what we call a pressor agent. These agents that called depressor are agents which increase blood pressure, and usually they are indicated in emergency cases where there is a severe hypotension of the patients. It will definitely produce reflex bradycardia because of this vasoconstrictor effect and massive increase in blood pressure. For that reason, it's indicated for severe hypotension, as well as it can be used as nasal congestion, so it's called decongestant because it will decrease the runny nose or the stuffy nose that's associated with the influenza or with the flu. Also, phenylephrine can also be given by ophthalmologists to examine the eye. So if they give phenylephrine, it will target alpha 1 receptors in the eye, to produce mydriasis that will increase or widen the pupils, so there is a better access for the doctor to examine the retina and other organs and tissues inside the eye without producing cycloplegia or without affecting the accommodation for the patient, which is opposite to the effect produced by parasympathetic antagonists. For alpha-2 selective agents, we have one example, which is clonidine. Clonidine will specifically bind to alpha-2 receptors, and it will activate these receptors that are located presynaptically and will produce feedback inhibition, so it will decrease further release of norepinephrine in the future. Clonidine is indicated for patients who have refractory hypertension that is not responsive for other common medications. For beta-1 selective, we have one example, which is dobutamine. So dobutamine will target the beta-1 receptors that are located on the heart to produce increase inotropic effect and increase in heart rate, so tachycardia and contractility, as well as increase in renin secretion that will lead to increase in total peripheral resistance. Dobutamine is sometimes a drug of choice in case of cardiogenic shock to keep the heart working during when heart stops working. For beta-2 selective agonists, we have a lot of examples, and these drugs are used widely in the clinics. These agents will mainly target beta-2 receptors that are located in the bronchi and in the liver and in the blood vessels. So they will produce bronchodilation, they will increase glucose levels through glycogenolysis, as well as they will produce vasodilation. These medications are widely used in people who suffer of asthma, so they are taken by inhalation, so their effect on the liver and blood vessels will be minimal. Examples of these agents include albuterol and terbutaline as short-acting, salmeterol and formoterol as long-acting agents. One last thing I want to mention about this class is that after chronic use of these agents or after high doses, they will lose selectivity on beta-2 receptors and start to target beta-1 receptors, producing some side effects. So we should be careful giving these agents for long periods for patients who suffer from some problems in the heart, such as hypertension or heart failure. Before the end of this lecture, we have to talk about two other classes in this category. First, drugs that target beta-3 and activates them. As a reminder, beta-3 receptors are located in the adipose tissue to produce lipolysis, as well as they are located in the smooth muscles of the urinary bladder to produce urinary retention. We have one example of a medication that targets this subtype receptor, which is mirabegron. So it's used in cases of overreactive bladder to decrease urination. Finally, we have one drug that can actually act through direct and indirect pathway. This drug is called ephedrine. Ephedrine can actually increase the release of norepinephrine from the presynaptic neuron, as well as the drug itself can directly activate alpha and beta receptors. So it stimulates norepinephrine release as well as activate the receptors postsynaptically without selectivity. It actually has similar effect to epinephrine because it targets all the receptors that are targeted by epinephrine, but some differences include it is less potent, it is not a catecholamine, and it has longer duration of action because it's not metabolized by the same enzymes that is metabolized by epinephrine. Clinically, this drug increase alertness as well as decrease the feeling of sleepy, so produce sleeplessness. And there is another drug that's derived or a stereoisomer of ephedrine, which is the pseudoephedrine. In the past, it was used a lot as a decongestant, but now alpha-1 agonists are used in alternative of pseudoephedrine, because pseudoephedrine sometimes is used to synthesize amphetamine, which is a drug of abuse. As a summary, this lecture talked about different drugs that either directly or indirectly activate sympathetic receptors such as alpha receptors and beta receptors. We talked about the advantages and disadvantages for their use, as well as we talked about the indication that indicate their use in the clinic. As a summary, some of the indications include emergency after acute cardiovascular, respiratory, and allergic disorders. We saw the effect of epinephrine on anaphylactic shock. These drugs sometimes can be used in cases of bronchospasm, especially during asthma and allergic reactions. We saw a couple of drugs that can target the nose and produce sinus decongestion. Also, because of some of these medications' effects on beta-2 receptors, they may be used in cases of uterine contraction. Glaucoma, these drugs can be helpful in treating glaucoma, as well as in cases of severe hypotension, we use vasopressor medications. Some contraindication of using these medications: patients who have cardiac problems such as arrhythmias, or cardiovascular problems such as hypertension or angina pectoris, people with hyperthyroidism or cerebrovascular diseases, or using these medications in distal areas where there's a single blood flow and a vasoconstricting this blood flow will produce necrosis, such as fingers, toes, nose, and ears. Also, caution should be taken when given to patients with renal impairment. Thank you so much for attending this lecture. Please let me know your questions, and I hope you enjoyed it.